Hello and welcome to the Progress Theory, where we discuss how to implement scientific principles to optimize human performance. On today's episode, we have Dr. Luke Hughes, a Post-Doctoral research fellow in applied exercise physiology from St Mary's University and an expert in blood flow restriction training. Now, I've noticed blood flow restriction training is getting more popular in the training space and on social media. You can buy blood flow restriction training cuffs more readily, and more people are utilising this method to enhance their training. However, is it worth the hype? What are the mechanisms behind blood flow restriction training? Like, how does it work? Can anyone use it? And can it be dangerous if used inappropriately? Well, Luke answers all of these questions, so everyone will be able to decide for themselves whether blood flow restriction training is for them and also how to use it. As always, follow at The Progress Theory on Instagram and YouTube. Head to our website, theprogresstheory.com, and have a listen to all of our other episodes. For now, here is Dr. Luke Hughes. Hey, Luke, how you doing?
Hey, Phil, I'm good, thanks. How are you?
I'm very well, thank you. Thank you so much for coming on the Progress Theory. I've wanted to discuss blood flow restriction training for a while. And the reason is because whenever I go on Instagram, well, let's take a step back, actually. If you think of sports science in general, there's a lot more equipment being more readily available in the market. Equipment's becoming more and more affordable, so more gyms are stocking these types of equipment. And I've noticed that for blood flow restriction training, there seems to be a current burst, especially you see it on Instagram. So I was trying to think to myself, a lot of people are now starting to use blood flow restriction training, but do they understand the mechanisms behind it? Are they doing it to the point where it could actually be dangerous if they're using it inappropriately, or they're using it to a point where it's not actually that effective? And I was like, I've got to get you on because I know you're the expert in this area and I've got lots of questions to ask from what I've seen. So thank you so much for coming on the show.
No problem at all. And thank you for the invite to come, and I'm happy to chat with you about it. And yeah, as you rightly said, it's become a bit of a craze in the last, especially the last 10 years. And then probably in the last 5 years is when we've seen, as you said, a bit of an explosion of BFR devices.
Yeah, the research has really sort of exploded the last 5 years. But since maybe it's lockdown, or maybe people are using Instagram and certain social medias more to show off what they're doing. And that's where people are starting to take notice. So I thought, well, okay, right, let's start talking about this. But before we go into the depths of the mechanisms behind blood flow restriction training, do you want to give a bit of an introduction of yourself?
Yeah, sure. So my name's Luke. I am originally from Wales, very proud Welshman. And yep, I was very proud in February this year with the Six Nations, but we won't go into that. So originally from Wales, I left there at 18 and went to Loughborough University in the East Midlands to study sports science. And my kind of research then was focused on cell culture. And then I then did a master's degree there, exercise physiology. And it was essentially actually an exercise immunology project. And we were looking at how we can manipulate exercise intensities and how we can change the inflammatory response to exercise and use this to help prescribe exercise treatment for patients with chronic kidney disease, which obviously is quite an inflammatory disease. And that's when I first my first exposure to how we can manipulate exercise and manipulate local physiology or systemic physiology to create some kind of response that we want. And then that's when I found blood flow restriction training. So the next step was moving down to London to do a PhD with Stephen Patterson. I'd never actually been to London in my entire life.
Really?
I think it was the furthest south. Yeah, I think it was the furthest south I've ever been. So, of being from North Wales. So, came down to St Mary's to do a PhD where I met you and shared an office with you.
Yeah,
great times, great memories.
Great times.
We were never very good at the pub quiz though, unfortunately. But aside from that, it was great fun. Yeah, and I did my PhD in blood flow restriction at St Mary's with Stephen, who had done his own PhD in blood flow restriction, and it was a collaboration with University College London Hospital, and we did a study where we used blood flow restriction in rehab for ACL patients, so following ACL reconstruction, and we did the first ever RCT in the NHS using BFR. So it was a pretty cool project.
Nice. And ever since then, really developed, hasn't it? Like you stayed with St Mary's and done even more stuff in blood flow restriction training.
Yeah, so post-PhD, I've been a postdoc researcher. So I've done my first 2 years and just had an extension of funding. So I've got another 2 years of research now, provided we can get back in the lab soon, because I've missed a good chunk of that due to COVID. But just kind of furthered the BFR research, and some of the kind of avenues we ventured down are things we found in the PhD. Some of them were related to our main outcome measures. Some of them were surprise things we found along the way, and we've kind of just tried to progress that now.
Yeah, that must have been really handy, because ultimately at the end of your PhD, you probably came away with a lot of knowledge, but a lot of questions as well. And the postdoc in this has allowed you to sort of expand on them a lot more.
Yeah, definitely. I mean, I think any good PhD, you come out with more questions than answers in some ways. Yeah. And I think definitely, I remember during my Viva, a lot of the discussion was around, what if and how could this be moved forward, and additional questions. And I think that's the fun part about it. But yeah, there's definitely lots of BFR papers coming out now. There's a handful each week. It's crazy, but there's still so much unanswered as well. So it's really an interesting area to work in.
Mm. So let's start at the beginning. What is blood flow restriction training?
Okay, so I suppose the kind of the easiest way to give an overview of it, it's when you use some form of a tourniquet and place it on your limb to restrict blood flow in that limb. And by tourniquet, any device that's designed to restrict blood flow can be classed as a tourniquet. So typically what we see in the blood flow restriction area in terms of research and practice is people will use different types of devices. So you have something from an automated regulated device, which can be like FDA approved. Then you can have a manual blood pressure cuff with a handheld pump. And then you can have anything right the way down to a TheraBand. So I see people use simple resistance band or cuffs and like knee wraps to restrict blood flow.
I think
so. Even those different devices.
I've even seen someone use like a bike inner tube once. Well, like when it started to get going, I've seen people use a bike inner tube as some form of tourniquet, mainly in the arms, I think. But I thought, wow, that's creative.
Yeah, definitely. Well, so one time I was in the gym near home, and I saw someone using a belt from their work trousers around their arm, and I was on the other side of the gym, and I was thinking, oh, don't say anything, just mind your own business. But at the same time, you're then worried that this person's going to hurt themselves. I'm sure we'll discuss that a bit after. But the general idea is that whatever device you're using, you place it proximally on the limb, so as proximal as possible. And then you inflate it or tighten it in some way, shape, or form to compress the underlying tissues, the underlying blood vessels, and then restrict blood flow to all the tissues like below and distal to that cuff, essentially.
Mm. Okay. And what are the mechanisms behind that? So why, if someone's like training, why would they want to do that?
So a lot of the early research around blood flow restriction training found that we can get significant muscle hypertrophy and strength improvements with it. And the key attractive factor is that we get these at a low exercise intensity. So the way I like to kind of describe it to people is if we think about adaptation, so if we focus on muscle adaptation, so hypertrophy and strength, there's kind of three key factors we can kind of pinpoint for muscle growth. So we've got, metabolic stress as a stimulus. We've got a high degree of mechanical tension, and then some level of mild trauma or damage to the fibers where they then regenerate and we get remodeling and we get hypertrophy. Typically, we know this is maximized with higher intensity exercise. So say 70, 75% 1 rep max or above. And this is what we've seen like the ACSM recommendations for resistance training. The interesting thing about blood flow restriction exercise, it's inherently low load. So we're looking at around 20 to 30% of 1 rep max, so significantly lower. And we know that level of intensity exercise performed by itself isn't enough to stimulate significant adaptation, at least when it's not performed to concentric failure. However, what we see is that when we perform blood flow restriction during that low intensity exercise, we get muscle hypertrophy and strength improvements, which can be comparable to what we get with high intensity exercise. So obviously that's a very attractive factor about it. If we think about blood flow restriction exercise, it's low load, so that level of mechanical tension is low. There's not a significant degree of myotrauma. So what we think is one of the biggest drivers is the level of metabolic stress that we create in that muscle, in those tissues when doing the exercise, because we make the tissues ischemic and hypoxic. So it creates one hell of an environment within the muscle.
Mm. And because you've used the low loads and I guess different adaptations there, the recovery is better. So if you had like a high load, the 75 to 80% loads versus the BFR load, but with 20%, because you've used the low loads, your response to that or recovery to that would be quicker. So potentially you could increase the frequency of doing it. You increase the frequency of your experiencing that metabolic environment you just described, which in turn could be better for developing hypertrophic type adaptations. Is that right?
Yeah, absolutely. So in terms of the recovery, like the initial fatigue is a high level of fatigue. So in the first hour post exercise, I'm trying to think back to, I remember the name of the authors, but one study where they showed in the hour post exercise, like maximum force reduction was way down. But it's an acute transient effect, and we recover pretty quickly. And yeah, it can be used as a high frequency off the back of that. And that's actually one of the most interesting areas of BFR research at the moment. I think for me anyway, there's a handful of studies that have looked at twice daily blood flow restriction training, 6-7 days a week for 3 weeks.
Oh, wow.
And they're showing like hypertrophy and strength improvements. And the magnitude of those improvements are what we'd see with like 12 weeks of training 2 or 3 times a week. So an area where it definitely is very attractive is intensive rehab. You know, if you've got an athlete who's injured and you want to rehab them quickly, whether that's post ACL or after, I don't know, a tendonitis or anything like that, it's a really good tool to kind of give them a bit of a blast and hit them pretty quick with it and get such a high volume of training in a short period of time. But obviously there's then considerations off the back of that in terms of, you know, muscle damage and overtraining as well.
Yeah.
It's finding that balance.
Yeah, of course. That was kind of be my next question, actually, regarding what kind of populations would you use this with? The most people that you see on social media using it are healthy gym goers, but I know you've done a lot of work with those that have had some form of knee injury. I think was one of your PhD studies with those that are recovering from ACL surgery.
Yeah, it was an ACL patient, so individuals who had a hamstring autograft, and we looked at using BFR post-surgery, and we compared it to the standard care. So the standard care at UCL Hospital at the time was to load them heavy, so 70% of 1 rep max, beginning at 3 weeks post-surgery. So we looked at using BFR instead and doing 30% 1 rep max, and we looked at, you know, what 8 weeks of training, which took them to about 3 months post-surgery. We looked at, you know, what was the effect on strength, what was the effect on muscle size, physical function, all these different things. So it's kind of circle back to the first point. For me, it's mostly beneficial for injured or load compromised individuals. So load compromised being so someone who's injured, so post surgery, as an example, or the elderly, individual with sarcopenia who's quite weak, high level of anabolic resistance. Those individuals seem to respond really well to it. So anyone who would benefit from the benefits of heavy training but can't tolerate that load for whatever reason, they're kind of, I think for me, the key target population. But there's also a whole other side to BFR now where it's like the performance side and how it could potentially be used in athletes to have different kinds of benefits, mostly from a load management perspective.
So it's about load management, as in they don't want to fatigue themselves too much from a large amount of training because it might affect their sporting performance. But using BFR might enable them to train more, but without the huge amount of fatigue that comes with training more, and ultimately have better adaptations, which could lead to improvements in performance.
Yeah, so I do some work with different football and rugby clubs, and one of the ways they're interested, and we've been discussing a lot recently, is how it can be used when they're not injured. And that's exactly what we've been discussing, using it in season to maintain muscle mass and the strength level without loading them too much and without fatiguing them. And I suppose really important if there's a particular time point where there's a high volume of fixtures, then I think around then it could be really useful. And then also like simple things like when you're traveling, if you're in hotel rooms quite a lot and potentially don't have access to gyms, I've taken the BFR cuff on holiday with me. I'm guilty of that. But it can be really useful in those situations as well. So it's not just a rehab tool, but for me, the biggest application is from a rehab perspective. Yeah.
And even with a busy week, a lot of training, that's implementing this type of BFR resistance training is not going to affect your other training. So say, for example, you've got a really busy week, you're a rugby player, and you've got training, then you've got field training, you're on grass, then you're back in the gym, with all that different training sort of clustered around each other, even though you get like after an hour of blood flow restriction training, you get that high level fatigue, but give yourself 2 hours, then you'd be recovered, ready for the grass training. And then, so you essentially can pack even more into a training week just because of how well you recover from this style of training.
Yeah, potentially, yeah. And I think that the key thing that for people to remember then is if they're considering doing that, it's just how you're going to monitor that. A particularly attractive thing about BFR training, particularly from a high frequency perspective, is that we don't see muscle damage, really, like we would with normal traditional high load resistance exercise, as an example. Interestingly, what a few studies have shown is that we get the response. So we get the inflammatory response. We get things occurring within the tissue as if muscle damage has occurred, whereas it hasn't, which is one of the ways we think it might be contributing to like tissue remodeling. But we don't typically see muscle damage like we would with normal exercise. There's been a couple of individual cases, but if you dig down into these, it's more related to the way BFR has been applied and the population it's been used in that are probably more, what's the word I'm looking for? Those factors probably contribute to any issues that have arisen rather than blood flow restriction per se. So it's using it smartly, using it correctly.
Okay. Speaking of using it for performance, I sent you a message the other day regarding its potential use for astronauts while in space, because obviously they can't. When you're in microgravity, you can't load the skeletal system as well, so you're not going to get that gravity response, which is allowing you to keep your muscle mass and your muscle strength. They do train for up to like 2 hours a day, but potentially the use of blood flow restriction training, they might be able to utilize that stimulus in a smaller area. So obviously when you're in the International Spaceship, for example, you can't have too much equipment up there, but using something like BFR means you could use lower loads, find a way of making sure that you can push against something, and surely that would then lead to a reduction in the amount of degradation your muscles would have when you're spending a lot of time in space.
Yeah, definitely. And I'm glad you brought that up. I know we spoke about this ourselves outside of work, but that is one of my main interests at the moment, because I think the applications are just glaringly obvious. We look at what happens to astronauts in space. There's several different physiological systems that decondition, where it's muscle, bone, cardiovascular, tendons. And essentially what we see, it mirrors the effects of what we see during bed rest and mobilization on Earth. And as you said, exercise is used on the space station. And they currently have the treadmill, the resisted exercise device, and an ergometer.
ARED.
ARED, yeah. And, as you rightly said, they don't have a lot of time for exercise. There's not a lot of space. And if you look at the goals of the space agencies at the minute, is to travel further into space, and it requires a new generation of spacecraft. And if you look at the Orion spacecraft, it's even more smaller. And they're going to be more concerned about packing food and water and oxygen supply into that. So there's not a lot of room for exercise equipment, and that's why I think BFR could really come in, because it would mean there's less loading capacity requirements aboard a spacecraft. The actual duration of the sessions themselves are pretty short. If you're doing a single exercise, it's about 5 to 6 minutes and you're done. So it can be relatively short, and you can use it along with you can use it with resistance exercise, aerobic, with electrical stimulation, and yeah, the possibilities are pretty endless with that.
Which one's the Orion mission? Is something
so the
coming
Orion,
up?
yeah, so it's the it's like the new generation of spacecraft that are going to be used for like lunar missions.
Okay.
So they're going to be building the Lunar Gateway, so the space station around the moon, to then create a lunar base and then onwards to Mars. So that's the new spacecraft, which is just, it's way smaller. There's already a lot of constraints on what they can take in terms of life support equipment, etc., research equipment, exercise stuff. But there's going to be even less room, and they're going to be traveling further. If we're thinking 7 months to Mars, we think about how deconditioned the astronauts. Like you see them land in the middle of the desert, and they have to be carried out, and they're so weak and fragile. And they start a reconditioning process like pretty much the next day. Like I know the European Space Agency one's like 3 weeks long as a minimum, and they started the day after because they're so deconditioned. But if you think about the longer duration travel, if they're going to travel to Mars, they need to be in good condition when they get there to land the spacecraft, get out, build a habitat, do all the surface exploration. So anything we could use to keep them, as physically fit as possible on the way would be good. And I think, BFR could definitely fit. We just need the space agencies to throw some money at us. That's what we need.
And
then we can do that stuff.
Yeah, because
as does every researcher need that.
Yeah, exactly. Grant money everywhere, hopefully.
Yeah, that'd be great.
I mean, we should probably, and we will probably collaborate a little bit more once we finish the podcast, because obviously I'm part of another research group which is looking at jumping in space. You're doing blood flow restriction in space. I'm thinking, and that was one of the reasons
jump
why
with blood flow restriction.
Well, exactly, yeah, and that's one of the reasons I started mentioning it, and then you go, "Oh, we've already got a paper of blood flow restrictions for astronauts in review or something like that." I was like, "Oh, right, you're a few steps ahead of me." But mate, that's a really exciting area.
Yeah, it really is, and I've been following the work you guys have been doing with the jump sled and stuff, and that's really cool. And hopefully that'll be up there on a parabolic flight as soon as possible for you guys.
Yeah, fingers crossed. Once COVID's out of the way, hopefully that will be the next thing to happen. I knew ESA were aiming to get to the moon for like 2023, and it looks like a number of government agencies are trying to do that as well. So it looks like a big collective effort. Well, space exploration is going to be a big thing in the next decade. So obviously astronauts need to be fit and healthy, whatever they're doing. So we need to make sure that
absolutely
providing the right training prescription to make sure that they don't get the degradation of the human body like they could do if they were in space for that long.
Exactly. And if this podcast gets enough exposure, maybe you can record one from the moon at some point and we can discuss this again in more depth.
Absolutely. I don't know if the Wi-Fi is going to be good enough.
It's probably better than the Wi-Fi at home. So.
What about sets and reps when it comes to blood flow restriction training? So I've been involved as like the participant in a number of studies, and quite often the sets and reps they prescribe for BFR seems to be 30 reps, then 15, then 15, then 15, with some kind of short rest periods in between. Where's that come from? And is that a kind of set and rep strategy you'd recommend for someone utilizing blood flow restriction training?
Yeah, so good question, and a question that pops up quite often, probably because of the answer, is that it's just, if I'm honest, it's something that was kind of done in early research, that set and rep scheme, and it worked, so it's been used again and again. So I like to try to explain it a little bit more than that. So you think what we're trying to do really, if we think back to what we said at the beginning about metabolic stress, we're trying to create a high degree of metabolic stress in the muscle. And the first, as you know, Phil, you've done a few of my studies, and the first 30 reps can be pretty easy. And it's when we've built up that metabolic stress and then we're trapping it in the muscle, because we're partially restricting arterial inflow, but we're completely restricting venous outflow. So as you know, there's no real recovery or relief in between sets. And that's when it starts to get really, really difficult. And what you'll find with most people is that they don't actually manage the 75 reps. Like we're pushing them, they're hitting concentric failure before that. So it's just something that's been used. There was one study back in 2013 that had looked at a training program, and they actually doubled the volume of exercise. So it was like 70, 30, 30, 30 reps. And and they reported that there was no further benefit on adaptation. So we know the 75 rep protocol, as it's commonly known, works. So it's just continued to be used. So another common one is performing 3 or 4 sets to failure. The problem you face there, and this is something that Stephen, my PhD supervisor, was telling me about from his PhD. When you perform sets to failure, you might have someone doing 120 reps in the first set, which is just, and then nothing in the set 2, which is ridiculous.
120, 5, 1.
Yeah, 125, 1, 0, and then a lot of pain. But what you find is that, in a clinical patient, our ACL patient, 3 weeks post-surgery, we're putting them on the leg press and we're doing single leg press, 30% 1 rep max. I'm not going to ask them to do 120 reps in the first set. That knee's already annoyed as it is. It's irritable. So, it's that approach, in my opinion, wouldn't really be feasible. It's definitely not the most feasible approach in a clinical application. But yeah, that set and rep scheme was kind of used and continued to work. So why fix it if it isn't broken?
Yeah. From that study you mentioned a little bit earlier, it does sound like there's a level of diminishing returns. You hit a certain level of reps, but after that, it's not going to have any further effects. So there's no point. But I guess, like you said, if the 30-15, 15-15 works, then why not continue using that or some variant of it? And then I guess you're just managing based on the situation, the person that you're working with, whether you're going to choose to go to failure, because ultimately that's going to affect if they can do one massive first set and then hardly anything after that. That's impressive that you get the BFR on those with ACL reconstructions 3 weeks after surgery. I didn't realize it was that early.
Yeah, that's what we did in my study in the PhD, so the final patient study, and people have used it earlier. So we followed like a criteria-driven approach to starting rehab. So we used the Lee Harrington protocol that was proposed. And beginning at 2 weeks after surgery, they had their sutures removed, and then we started assessing them every 48 hours. And once they could hit certain criteria, we retested their 10RM, and then we started training. So we did that, so it's obviously everyone recovers differently, so everyone would kind of start from a set point, but it worked out between our 2 intervention groups. I think it was like one was 21 days and one was 22 days post-surgery when we began. So at the time that was pretty early for ACL rehab, but I know individuals and cases who put it on 3 or 4 days post-surgery in a different manner, not with resistance exercise, in combination with electrical stimulation or isometric exercise or passive movement or something else.
Or even walking?
But walking's a big one. This is still the area of BFR research that baffles me, because and I think it's one of the most interesting areas is that we see that when we put the cuff on during low intensity aerobic exercise, we get improvements in muscle mass and strength, which you wouldn't normally expect with aerobic type exercise of any intensity. And then we also see improvements in aerobic capacity and vascular changes as well. So I think that's a really, really key thing for rehab, because, if we have an ACL patient in a leg brace for a week after surgery, if we think they're in that leg brace for that first week, they're just atrophying. So they're losing muscle size, they're losing strength. And then once we get them ambulating, they're just maintaining what they have, or even still losing them. So putting the BFR on in the aerobic walking, cycling can have a really big impact there. I think you're going to see a lot more clinical studies looking at aerobic exercise in the next 3, 4, 5 years.
Oh, wow. What's the common mistakes you see people using with blood flow restriction training? And the reason I ask that now is because I reckon someone hearing that for the first time, saying that you're getting blood flow restriction training on someone that's just had very serious surgery, is like, oh, that's a bit dodgy. However, it sounds very logical and seems to have a very positive effect. But is there anything that people could do, whether it's with an injured population, elderly population, or just a healthy, I want to develop hypertrophy type population, where people make common mistakes?
Yeah, absolutely. A couple of key things jump to mind there. So the first kind of one really, and the main one, is the pressure that's applied. So Typically, devices like outside of Japan will apply pressure in millimeters of mercury. So what we saw, like what I found in the literature when I first began my PhD and did a review of the literature, everyone was using different pressures, and I couldn't figure out why. And what you might see is that in one study cohort, the same pressure is applied to all individuals. But the problem with that is that we're going to get different levels of blood flow reduction in the individuals. Like we both know that I've got way more muscle mass on my legs than you. So if we put the same pressure on me and you, you're going to get your blood flow reduced more because you have less limb tissue. And the issue there is that, let's say, what we want to do with BFR is we want to partially restrict the arterial inflow. We want to restrict it enough to cause this metabolic stress and cause enough changes to local tissue physiology, but we don't want to completely restrict arterial blood flow because it might increase the risk of an adverse event occurring. So if we use the same pressure on all individuals, some people might be fully occluded at 150 millimeters of mercury. Their arterial blood flow might be completely cut off, whereas another individual with bigger limbs might not experience much blood flow reduction at all. And one of the biggest issues we see in practice and in research is that people will still do that. They'll pick an arbitrary pressure based on a previous study and apply it to everyone. And the best way around that is to standardize it. So because things like systolic blood pressure, limb size, circumference, contractile state, tissue composition can all affect it, what we do is we calculate something known as limb occlusion pressure. So that essentially is the pressure, the minimum pressure required to completely restrict all the blood flow in that limb, all the arterial blood flow. We calculate that pressure and then we prescribe as a percentage of that. So we individualize it and personalize it to every individual. And that's kind of where the research is moving quicker than clinical practice, which quite often can tend to be the case. We're starting to see more of it, but not enough. There's still research being published that doesn't really individualize the pressure. And for me, if you're going to put it in a clinical population, I want to be confident that I'm restricting blood flow to the desired level. And I'm not causing too much occlusion from a safety perspective, but also from an effectiveness perspective. If we don't create enough stimulus, then we're not going to get the full benefits of the training. So it's that balance of the safety and effectiveness. It's not just for one of them, it's for both, really.
Yeah. Is there a level, like you said, there's 100% occlusion, which probably a bit too much. Is it like 80%, 70%? What's like a common value? Like I know it's very multifactorial, but is there a common value that keeps coming up?
Yeah, so it seems, based on what's been published so far and what we know, it seems that between 40 and 80% of limb occlusion pressure is kind of the effective, like Goldilocks zone almost. So anything above 80%, we're getting dangerously close to full occlusion, and it kind of becomes a bit too, the discomfort becomes a bit too unbearable for some people. Whereas anything below 40 might be a bit easy. That's when you might be able to bang out 120 reps in every set because it's actually not too difficult. So, which obviously we do that. We do that anyway, Phil.
Yeah, I can imagine someone like, okay, I've got my arms all tourniqueted up, I'm ready for this, and just doing like 4 sets of 120 reps. And you're like, oh shit, didn't do that right.
Yeah,
I've just wasted time.
Limbs just fall off after. Yeah. But yeah, it should be, as you know yourself, you've done some of our studies, it should be difficult. So that's kind of the key one. It's making sure you individualize the pressure. And then related to that, it's the device that you use. If someone's tying a TheraBand around their limb or a bicycle inner tube, you have no idea what pressure you're applying.
Yeah.
And also, for me, you cannot be consistent with that pressure across sessions. You can't say, oh, this is how tight it was last time. Because again, multifactorial, multiple things can influence that. So using a device where you can actually A, see the pressure, but B, also a device that's designed to regulate the pressure. And the reason I say that is because one of my first PhD studies, we looked at different types of BFR devices that were on the market at the time. Now, this was 2017 when we did this, so there was significantly less devices available at the time. But we had 3 different types, and we had a a handheld pump, like blood pressure sphig type device. We had a surgical tourniquet, which is designed to regulate pressure. And then we had like a Hulkinson device, which is a rapid inflation cuff. And we developed this system where we put pressure sensors between the cuff and the limb and actually measured what was happening, the interface pressure between the cuff and the limb, because it was evident to me that in the papers, people were saying, right, we applied 150 millimeters of mercury. It's like, okay, but do we actually know that's what the limb's subjected to? Like, some of these cuffs are thick, some are thin, some are wide, narrow. How well is that pressure being, transmitted to the tissues? And essentially what we found is that in a cuff that isn't designed to regulate pressure, we saw big spikes in the superficial tissue pressure. So if you think, for example, we tie a TheraBand around your arm that's not designed to change, and then we get concentric muscle action, and the muscle gets shorter and fatter, and it pushes up against that cuff. It actually exposes the tissue to a greater pressure and a greater pressure gradient. And what we found is that cuffs that weren't designed to regulate, that would happen. So we could see almost like 50% more of the pressure that was set being applied. And this was resulting in more discomfort, higher pain scores, a greater hemodynamic response. Whereas in a cuff that was designed to regulate and adapt to changes in movement, the pressure changes were smaller, and then the perceptual and hemodynamic responses were less. So I would also advise to use a device that is designed to do that.
Okay.
Especially when working with a clinical population.
Yeah, certainly. Well, that kind of leads into my next question, was because there's so many new products out there, what are the key things that if people want to buy some form of apparatus for blood flow restriction training, what should they look for?
So a couple of key points. So ideally you want a device that can in some way, shape or form calculate limb occlusion pressure. That's our gold standard now for setting pressure and individualizing it for every individual. So there's a handful of devices now that have built-in limb occlusion pressure technology, where it will personalize it at that moment, that time of day for that person, and then you can repeat that every time. So I think that's a key factor. Related to that, it's ensuring that the device is actually doing what it's doing, because there's a lot of new devices that are coming out that claim it's measuring limb occlusion pressure or some other form or some other way of standardizing pressure, but they're yet to go through validation studies for the equipment itself or show effectiveness in a training study as well. So it's early days for those yet. I'm sure we'll see research come out. So ones that can regulate pressure, calculate LOP, and then just ones that have scientific evidence behind them. They have published scientific peer-reviewed literature to support them, support their safety, support their effectiveness. Again, more so if you're using it in the clinical population.
I'm not going to mention any brands here, but those that almost have a tourniquet built into either a t-shirt, a pair of shorts, where you can just sort of like pull it, create some form of occlusion. Do you think they work, or do they work to some extent, or is it just too potentially dangerous, because then you're just auto-regulating it as yourself and you could end up completely strangling the limb and causing some damage?
Yeah, so those type of BFI devices are probably the only type I haven't got my hands on yet. But my thoughts on that, if you think about it logically, it's kind of similar to just using a TheraBand. Like you can't, there's no way you can, perhaps there is, but to me, I can't see that there's any way you can actually, objectively and accurately quantify the level of pressure applied. Are we making sure that pressure is even circumferentially around the limb? How is it changing during exercise? If we're moving with these devices on, is it designed to regulate pressure, or are we going to get big spikes in pressure like we just spoke about with some other devices? So I'm sure there is some level of blood flow reduction to an extent, like if you wore a really, really small t-shirt, but whether or not that's going to be effective for creating a significant stimulus for adaptation, I don't know. And I'm pretty skeptical about whether, personally, I don't think that would be the case, but I'm sure there's probably research being planned already ongoing with those types of devices.
Yeah.
So we'll see.
It'll be interesting to see where it goes anyway.
Yeah, definitely.
So I set up on Instagram an opportunity for people to throw in some questions. And there's 3 I was going to throw your way, if that's all right.
Sure.
So first one's from Cole Vincent. He wanted to know a little bit around blood flow restriction training on the possibility of it helping with pain reduction. He didn't specify what the pain was, but has it been utilized to try and reduce pain, especially with those that have been injured?
Yeah, it's a great question. And that's actually kind of the primary focus of my current postdoc research. So it's a question I'm definitely happy to talk about. So we know exercise itself causes pain reduction. It's often called exercise-induced hypoalgesia. And what we know from years of research is that the more intense the exercise and the longer the duration, the greater that effect. And then, so, 70% 1RM and 20 minutes plus, for example. What we've seen in only a handful of, there's less than 5 BFR studies showing this, but what we've seen is that if we apply blood flow restriction during low intensity exercise, we create a greater hypoalgesia effect. And that was a study we did last year, which we got published in JAP, which is a really good paper. And we looked at pain sensitivity to like a mechanical pain stimulus pre and post exercise. And essentially what we found is that we had a low intensity exercise group. It's like 30% of 1 rep max. And when we added the blood flow restriction to that, we caused a greater reduction in pain sensitivity, which was great. And actually, when we used a higher BFR pressure, so like 80% limb occlusion pressure, the effect we got was greater than what we saw with high intensity exercise. And that kind of reflects some of the clinical studies where they've compared high intensity training and BFR training over 8 weeks. And they found, in a clinical population, there's a greater reduction in pain over training in the BFR group. So I wanted to start digging around that and try and figure out if something is actually occurring, what the potential mechanisms are, and if there's something going on, how could we optimize it?
What's the plan going forward with that? What's, I guess, from study, I don't have to go into too much depth regarding study design, but what's the next research question? So
we did a study in healthy, non-injured, pain-free individuals with resistance exercise. We've repeated that with aerobic exercise to see if there's a similar effect, because we see exercise-induced hypoalgesia both with resistance and aerobic. So I'm trying BFR in both. And then the next step is to use it in a population with chronic pain. So whether that's someone with anterior knee pain, patellofemoral pain, hip pain, anything like that, just to see, okay, does it have the same effect? Because one thing we see within the literature is sometimes in people with pain, exercise makes it worse. So we get hyperalgesia and it actually makes things worse for them. So the next step is to put the BFR in that clinical population and go, right, acute hyperalgesia, are we seeing the same as what we see in pain-free individuals in terms of pain sensitivity to a stimulus? And see if that works.
Well, that's wicked. I'm going to look forward to looking out for that. That's really
You'll be taking part in some of those studies.
Most likely, yeah. I'm sure I'll get like a message not too long after this.
Yep.
I've got to keep it going. I'm in most of your studies, so I need to keep that going.
I think you've done every single one bar the ACL trial, which I'm glad you weren't part of that because it meant you didn't have a recent ACL injury. But
recent
at the time, recent. Yeah, hence why I said
you did
recent,
it a bit earlier. I've been right up your street there. I think me as a participant.
Pilot study on Phil.
Yeah. So the next one was by Lars Kemperman. Can blood flow restriction training increase capillarization in muscles with a big cross-sectional area?
Good question.
On this.
So, good question. So there's not a great deal of research on either the magnitude or timing of microvascular adaptations to BFR training. So one particularly interesting study, and it is kind of coming back to that high frequency thing we spoke about earlier, that high frequency application by Nielsen et al. Last year. And they did basically a 3-week high frequency program of twice daily BFR training. And they looked at multiple things, but one of the things they examined was microvascular adaptations. And what they found essentially is that There was an increased number of capillaries per myofiber and increased capillary area following training. They also saw in that study myofiber hypertrophy, so the actual capillary density itself remained unchanged. But one thing I found particularly interesting about this study is that the magnitude of changes that they saw in 3 weeks were basically the same as what we'd expect after 2 or 3 months of strength or endurance training. So, the level of change in capillarization was equivalent to 2 or 3 months of training, but with 3 weeks. So that was kind of, for me, is the best study in that area at the moment, and I'm sure there'll be many more following up their methodology. And the key thing I think there is to look at how does that compare with 2 or 3 times a week of BFR training? Do we see the same effects, or do we need a high frequency approach for that?
Yeah. No wonder BFR has got so popular in the last decade and now is really growing with the sort of healthy population. Like, if we're seeing adaptations that quick, like that's in the third of a time, that's really quite incredible.
Yeah, it really is. And we're seeing the same with hypertrophy and strength. Some of the early studies out of Japan, they were seeing changes in like hypertrophy of 2 weeks. Like, yes, they're doing 5 sessions per week, so it's 10 sessions, but 2 weeks. So that's why I think it's a really, really good intensive rehab tool to use to someone in the early phases of rehab to accelerate recovery. But also, if you think from an elite performance perspective, like get them back quicker. And, to football clubs and rugby clubs, that's really beneficial because those players are being paid. If they're injured, they're being paid a lot of money to sit on the bench. So they want them back quicker.
Yeah, I was just saying that's money. That's going to save indirectly save the clubs millions of pounds almost, if it has these effects with the injured population as it potentially can do. Yeah, and
so one of the key factors here is that there is a body of research on athletes, so highly trained individuals, where they've taken them, so they're doing resistance training at the time, and they take them out of that program and they put them on a BFR program. So they reduce the load from 80% 1RM down to 20-30%, and we still see some form of adaptation, probably because it's an unaccustomed stimulus, but that typically the magnitude is quite small there. So again, it's being realistic about what we're expecting to get from it, but we do see adaptations in athletes and healthy individuals, so obviously it's not just useful for injured.
And the last question is by my boy Adam Matusi. And it kind of covers what we talked about earlier regarding what type of cuff or what the factors we need to take into consideration when maybe purchasing a cuff. So thoughts on cuffs that auto-regulate occlusion pressure, such as air bands, and I won't mention the brands, but you're quite familiar. So what's your opinion on those cuffs that are coming out now, which propose that they auto-regulate the pressure?
Yeah, so good question. As we mentioned earlier, that's one of the things I think is a key factor with the BFR device, so that it can calculate LOP, but also actually regulate it. Regulated devices that regulate pressure are much more beneficial to me and safer. The key thing with all the ones coming out now that are claiming to do this is, are they actually doing that? So, I want to see scientific peer-reviewed evidence published and the same findings from several independent research groups that the devices are actually doing what they say they are. There's a handful of devices, a couple that have been validated. I did some validation work on one type in my PhD, and we know it's doing what it says it's doing. So I suppose my thoughts are, if the research comes out to support the claims, then great. We know it's doing what it says it is, but until then, I would be reluctant to use those in the clinical population, especially.
Yeah. So the question involves that, I'll say the brand names, the air bands by Vald and by Suji, but I guess before you purchase them, do a bit of research regarding how well they've been used within the research. Have they been validated? Are they reliable? And then if they have and you've seen the research, then they should be a pretty good purchase.
Yeah, and I mean, the same goes for all aspects of life. If you're going to buy a new laptop or buy a new car or a new bike, you do a bit of research first before. And if it's got bad reviews or no reviews, that puts me off. So, I think the same goes here. you want to be sure that what you're buying does what it says it does. And especially when it's something like autoregulation of pressure. And I think I'm quite a big advocate of that because of the study I did in the PhD, because obviously you have we have a lot of pride over your PhD studies, but for me, that was a really, really novel finding, is that we were showing this spike in pressure, and that was potentially explaining differences in the level of discomfort between devices, etc. So for me, that regulation is really, really important, and you want to be sure that the devices are actually doing it properly. So they're regulating properly, but they're also calculating or individualizing pressure properly as well.
Yeah. Right. This whole topic is really, really interesting. If someone wanted to learn a bit more about blood flow restriction training, like, what can they do? Where can they go? Are there courses, anything that you're involved in, which you're teaching, that they can sign up to?
Yeah, so I think there's a lot of blood flow restriction courses around now. It's both in person and online. One particular group that I've done some work with is Owens Recovery Science, who are based over in the States. They teach BFR courses focused around rehab, and they're all over the US, and now they've moved into UK and Europe, and I teach on the London courses for them. So if you go to their website, you'll see courses listed all over the world there, and anyone can sign up. You need to be a clinician of sorts, but any clinician can sign up. And I suppose reading research papers as well. Some of the recent papers that are out, and myself and boss Stephen were involved in a consensus paper with a group of individuals, 10, 12 individuals from around the world who are kind of experts in BFR and world leading researchers. And we all did a paper and covered kind of everything we knew about BFR to date. So reading something like that, I think, would be very useful, particularly for the BFR novice. And yeah, I suppose things like this, podcasts, there's lots of online educational resources around BFR training now. So there's plenty there for individuals to begin with.
Yeah, definitely. Well, I'll definitely put your paper, I know which paper you're referring to, I've read that. And I'll definitely put the link up to the courses in the show notes. What's the name of the course again? Just the one that you teach, the London branch?
Sure, it's owensrecoveryscience.com. You'll find everything listed there, and I can send you a link if you want for individuals to look at.
If anyone has any further questions, how can they send you a message?
Yeah, so you can contact me on Instagram if you wish, anyone. I'm assuming Phil will tag me in these things, so feel free to message me there. Yeah, of course. And then, via email. So my St. Mary's email address is listed on the staff website somewhere, probably with a very embarrassing photo of me. So you'll find me there. Feel free to email me there, and Twitter as well. As I said, I'm sure you'll tag me in all of this, so I'm happy for anyone to use those to message me if they have questions.
I'll put your Twitter and Instagram handles in the show notes and everything. Right, brilliant.
Thanks, man.
As a last question, if you had to pick one guest to come on this podcast, it doesn't necessarily have to be within blood flow restriction training, but someone that you'd love to listen to, who would that guest be?
Aside from Jurgen Klopp, who would probably be my first number one choice, being a big Liverpool fan, and someone astronaut related like Tim Peake, I would probably say my old PhD supervisor, Ben Rosenblatt, who works at England football at the minute. I don't know if you've thought about having him on, but I've
met Ben. So yeah, a really nice guy. I think I'll definitely will contact him in the near future, I think.
Yeah, do it. And if you need a hand convincing him, I'll try and help you out. I don't know how much of a hold I have on his heartstrings anymore, but I think he'd be really good. He's told me some really cool stories from his time working in high performance sport over the years. So I think, and such an incredibly knowledgeable guy. Every time I hear him speak, I learn something new. So I think that would be a cool guy to have on for the podcast.
No, brilliant. That's definitely a good choice. Anyways, Luke, that was brilliant. Thank you so much. I certainly learned a lot of that, and really excited for your future research, especially the stuff that's involving going to both the moon and Mars. I'm keeping an eye out on that one.
Yeah, absolutely. We'll chat about that more later this week.
Sounds good to me, mate.
Great.
Cheers for that.
Cheers,
Perfect.
Will.